dissertation is going to be given by Tejaswi Materla. She is the person who is the recipient of the Riccardo Dell'Anna doctoral dissertation prize. So I asked her if she would please give us an overview of her dissertation, and then we will have time for questions and answers. So I will turn it over. Let me see. I think I need to make sure that she can share her screen.
I do have the option of sharing my screen.
Perfect.
Yeah, thank you. Hello, everyone. My name is Tejaswi, and I will be presenting my doctoral research today. Liz, it looks like you have disabled participant screen sharing. So when I clicked on the screen sharing, it did not allow me to. Les, you're on mute.
Oh, sorry. Yes, you should be good now. You should be able to share your screen now.
Okay, thank you.
Paul, will you please put yourself on mute?
What do you see? I can't do anything that I can't see myself, but I see all the slides and all your faces, but not myself. Do you see me?
No.
No. I don't know what happened.
Your camera's not on.
No.
The mute is down at the bottom.
Paul, I'll go ahead and mute you. In fact, I'm going to mute everybody. So Tejaswi, if you can unmute yourself.
Yes, I just did. Thank you. So hi, everyone. My name is Tejaswi Materla, and I will be presenting my dissertation on analyzing factors affecting patient satisfaction using the Kano model. So I wanted to give you a little introduction about me. So I received my PhD and master's in engineering management from Missouri University of Science and Technology, and I have my undergraduate in electrical and electronics engineering. I'm currently working as an assistant professor at Penn State in the Abington campus, and I've worked for a couple of years as a software quality engineer as well as software engineer. So, okay. So my research started with a lot of different objectives, trying to understand how to capture the voice of patients in the healthcare industry. So looking at the need for quality improvement, we noticed that healthcare is one of the largest and fastest growing industries in the world, right? And healthcare providers and organizations do face a lot of challenges when it comes to identifying these customer needs, their expectations, and also to understand their experience, which usually tends to lead to poor quality of care, lower satisfaction, and really excessive cost. So as healthcare costs continue to rise, all the providers are focusing on patient satisfaction to manage these costs and enhance the service quality. And that is a really complex function when we look at patient satisfaction, because it's not just perceived needs and expectations, but also their overall healthcare experience, right? So the focus behind all that is when we try to understand this quality perception and their experience, we need to really put our focus into that, as it impacts their satisfaction, the service consumption, as well as loyalty and business growth, right? So the statistics that you would see is mostly in US-based statistics right now, as my research focused on looking at walk-in clinics as well as student health services and the other healthcare service units. So according to the US Department of Health and Human Services, the total national expenditure was $3.2 trillion in 2015. and it continues to grow at around 6% every year. The Organization for Economic Cooperation and Development, they suggest that US ranks the highest when it comes to healthcare expenditure, which is followed by France and UK. And we also do have the worst outcomes in life expectancy, obesity, and infant mortality compared to the 12 other high-income nations such as UK, Australia, Canada, Denmark, and others. Despite spending so much on the healthcare expenditures, the quality, however, lags far behind. And we need to focus on patient satisfaction to understand how we can enhance that service quality. So my research focused on a few of the objectives to try to identify several different quality attributes that will have an impact not only on satisfaction, but also dissatisfaction in healthcare. To understand if there are any differences in different market segments based on demographics, based on whether it's an existing or a new healthcare service unit that is being constructed. The objective was to develop a methodology that includes the Kano model to identify patient needs, to maximize the satisfaction, and improve the quality perception of diverse healthcare units. So the focus was on looking at different types of care and services, changes in demographic environment, customization of care, and treatment of options. With this methodology, the aim was to eliminate the gap between patients' quality perception and their actual experiences. So to give you a brief overview of the Kano model, so the idea behind this, so traditionally we were looking at a one-dimensional model where there was a linear relationship between the product or service quality and satisfaction. However, Dr. Kano, along with his colleagues, extrapolated the Hertzberg two-factor theory, which focuses on motivators and hygiene factors, and developed this model, which can identify quality attributes based on how they would impact both satisfaction and dissatisfaction, and suggested that the linear relationship is not valid. And with the Kano model, you can classify all these quality attributes of a product or a service organization into must be, attractive, one-dimensional, in different categories. And I will go through each of those. So with the must be attributes, these are basic requirements of a product or service quality, and their absence usually tends to lead to extreme customer dissatisfaction. However, when they are present, they do not have any impact on satisfaction. So one of the examples that I would like to always use is that everybody owns a car, right? Or at least has driven one in their life, right? So with must-be attributes, think about it. If you have a car that has good brakes, that's necessary. When it's not present, it would lead to a lot of dissatisfaction. But when it is present, it's expected. It's a must-be quality, right? A one-dimensional attribute is where you have the level of performance that is directly proportional to the satisfaction. So the more gas mileage you get, the more satisfied you get, right? With attractive attributes, when they are present, it leads to a lot of satisfaction. However, when they are absent, it doesn't really affect the customers. They don't even notice those attributes. So think about it when we are paying for a basic car, and we would get it fitted with a lot of technological attributes such as backup camera or navigation that would really increase the satisfaction. However, I'm paying just the basic amount, so I wasn't even expecting that attribute to be present. So it definitely improves my satisfaction when I've been provided those attributes. With indifferent attributes, these have no effect on customer satisfaction or dissatisfaction. With reverse attributes, when present, they lead to dissatisfaction. However, when absent, they lead to a lot of satisfaction. So with most of the product industries, most of the products, it's very easy to identify which attribute is an attractive or a must be or reverse indifferent. However, it's very difficult to look at the service industries, especially the healthcare industry, to try to figure out which attributes actually impact more on the satisfaction and which attributes impact more on the dissatisfaction. So that was the goal, to try to use the Kano model in healthcare industry to understand the voice of patients. So my first step was to conduct a literature review to identify which studies had actually used Kano model in the healthcare industry. And I've received about 227 search results. Out of those, only 17 of those studies actually implemented the Kano model in the healthcare industry. Some of them have used Kano model by itself. So one of the studies by Gustafsson looked at quality attributes of children and women's healthcare department, where they identified several different attributes and noticed that communication between the aftercare ward and neo ward and the minimum distance were really considered important as a must-be attribute. Some of the other studies utilized Kano model along with the quality functional deployment. One of the studies by Shamsharaz and Dong looked at adult care homes in London and identified 12 different needs of care home residents, and observed that accessible equipment, home-like environment, and suitable facility design were really important, were must-be attributes. Some of the other studies utilized Kano model along with ServQual, which is the service quality scale, looking at responsiveness, tangible, reliability dimensions. And one of the studies conducted by Vasiladis and his colleagues looked at outpatient care unit and observed that personal attention and providing information on when the services would be provided were considered must-be. Kano model was also used with other methodologies such as blueprint, service blueprint, where they looked at different attributes of adult daycare center and try to implement that in their service blueprint process, which is a process map, and observed that transportation services and bus drivers' attitude were really important, were must be. However, looking at all of these studies which implemented Kano model along with other methodologies such as ServQual or QFD, we've noticed that these studies only gained momentum in late 2000s, and there were various factors that actually influenced their decision to implement the Kano model to understand voice of patients. Some of the factors are medical tourism, population aging, emergence of corporate care service, and economic recession. What I've observed in these studies is that there was always a generic scale that was used to identify the voice of patients or customer needs, and it was just implemented in every service unit. However, the patient needs tend to vary with the type of care that is acquired and the services that are offered. And these scales and these studies did not use any customization according to those. And that was my goal of trying to look at that and develop a methodology that can look at both new healthcare units as well as existing healthcare units, trying to look at diverse services that they provide, and then classifying these quality attributes. So my methodology focused on 4 different steps: defining the need, Kano analysis, statistical analysis, and the focus really is on continuous improvement, where we look at longitudinal as well as locational analysis. So in the first phase, when implementing this methodology at any healthcare unit, we have to try to identify whether it's a new service or an existing service, and the types of different services and care that is provided, gathering information through preliminary satisfaction surveys, where we look at patient complaints, grievances, utilizing the HCAP survey, which already gives you information on a lot of different service quality attributes, and trying to customize it to the specific healthcare service unit, and focusing more on the demographics. So with the next step, performing the Kano analysis, we really have to focus on Making sure that the Kano survey is customized. Attributes are always randomized to avoid biased results. And each question that we ask about any service quality attribute must focus on both functional aspect as well as dysfunctional aspect, and should only investigate one single attribute at a time. Otherwise, trying to combine multiple attributes and trying to figure out which is more important tends to be very difficult. So our goal has to be with focusing on one attribute at a time and focusing on both functional and dysfunctional aspect of that attribute to avoid incorrect categorization using the Kano model. Using that survey and disseminating it through several different avenues that we have, and the completed responses must be analyzed using frequency analysis, making sure that we are calculating the Cronbach's alpha to ensure reliability of the survey that we use, using the chi-square goodness of fit test to compare the observed frequencies with the expected to ensure that the responses that we gather are statistically significant. The next step, where we look at the statistical analysis, we use the Fisher's exact test to understand the demographics, making sure we are also calculating effect sizes, which give us information on quantitative indexes of relationships among different variables. That really gives us a lot of information on how the customer needs change with demographics such as gender, age, their residency status, parental status. So a lot of different demographics that we would like to analyze. In the last step, the focus is going to be on the continuous improvement part, as we only get one responses for each attribute when we conduct it as a cross-sectional study. However, performing the longitudinal analysis gives us information on patient needs and how they vary over time. And also performing the locational analysis gives us information on how these needs vary based on demographics and vary based on the healthcare service unit that we are trying to focus on. So using this methodology, I've conducted two studies, one with the walk-in clinics, as well as one with the University Student Health Services. And my advisor, Dr. Kadni, is currently using that at Phelps County Regional Medical Center to analyze customer needs for the diabetic education and wound care unit. So with the walk-in clinics, so these are usually referred to as doc in a box or a retail clinic. They can be found at pharmacy chains, supermarkets, and even airports. They are common in both high income as well as lower income communities. They accept commercial, Medicare and Medicaid coverage, and the focus is mostly on acute care services. They are different when we compare them to hospital units in terms of physical and administrative structure. They are usually staffed with licensed physicians, such as physician extenders, such as nurse practitioners and physician assistants. They do, however, only focus on acute care services, such as cold, cough, but a lot of the population tends to use these walk-in clinics because of the ease of use and affordable cost and different payment plans. So most patients that utilize walk-in clinics are less likely to have insurance or primary care provider. According to the US Department of Health and Human Services, there were about 28.2 million patients below the age of 65 who were uninsured in 2016. These walk-in clinics tend to receive about 10.5 million visits annually. They generate revenue about 500,000 per year, serve about 10 to 30 patients per day at a cost of about $75 per visit. They are favored by patients because of the convenience in terms of cash payment, accessible location, and hours of operation. But the challenges still exist when we look at walk-in clinics, because they only focus on acute care services and not really the improvement of the health of the patients, the individuals, and communities. So there's no consistency in terms of their regular improvement of quality of life. And it's also disconnected with the rest of the healthcare system in terms of how information is acquired for the patients. So my goal was to look at these walk-in clinics and identify the different types of attributes that can be focused on to improve that quality of care that's received from these walk-in clinics. Some of the attributes that the scale that I've developed looked at availability of appropriately qualified medical staff within 10 minutes of check-in process, provision of after-hours care, good communication among medical staff, provision of clear instructions, sympathetic and reassuring medical staff. We also looked at accommodating religious and cultural restrictions, friendliness of staff, and so on. So this survey was deployed via Qualtrics to all of the enrolled students at our university, Missouri University of Science and Technology, but also to the general public on social media websites such as LinkedIn, Facebook. And the survey looked at 42 randomized questions. So each of these attributes that I just talked about, these were divided into two different components, functional aspect as well as dysfunctional aspect. And they focused on these 22 quality attributes, and we've gathered 8 general and demographic questions. We received about 127 responses, out of which only 77 were considered, and we had to eliminate 50 of them because of incomplete data. So let's take a look at one of the examples that we have here. So one of the attributes where we looked at delays. So the question was divided into 2 different aspects, where the functional aspect focused on if the staff keeps you informed about the delays, if any, during your visit, how would you feel? And we used the Kano scale. And also looked at dysfunctional aspect, where we talked about if the staff does not keep you informed about the delays, how would you feel, or what is your response? So each question was divided into these 2 different aspects. We've also gathered demographic questions, which we try to use to understand if there are any differences between the patient responses based on age, based on gender, based on health status, whether they are US citizen, their marital status, as well as whether they had kids, so parental status. And we've received a lot of variation in that. And this was used with the Fisher's exact test to understand the differences. So for the example that we just talked about, where we focused on the quality attribute about delays, the responses for each individual survey respondent were classified using the Kano evaluation table into one-dimensional, attractive, must be, questionable, reverse, and indifferent. And with this, we've gathered all the responses for each individual survey respondent, and the attribute for each individual quality attribute about the walk-in clinics was classified. So for the example that we just saw, this was classified as one-dimensional attribute, and we've calculated several information about this attribute, such as category strength, which gives us the estimated value or strength of the attribute in terms of highest and the second highest, to make sure that this really is a one-dimensional attribute. We've also calculated this total strength, the estimated value of the attribute based on the satisfaction that it creates. So in terms of attractive, one-dimensional, and must be. 2 other aspects of this quality attribute, such as better, which is the extent of satisfaction this attribute can create when present. That was calculated, as well as the extent of dissatisfaction this attribute can create when absent. That is worse, that has been calculated as well. So all these 21 attributes with the responses from the 77 respondents was categorized into must be, attractive, one-dimensional, reverse, questionable, and indifferent. And we've noticed that there were 11 must be attributes. 13 of those were considered attractive, 33 were one-dimensional, and 20 of them were indifferent. for this attribute of delays. Okay. So the patients categorized 15 of the service quality attributes as one-dimensional, 3 as indifferent, 2 as attractive, and 1 as must be. And what you will notice is that all these quality attributes right now on the model look as just the one single points. If we performed the longitudinal analysis, these points would turn into the regular Kano model. So the attractive attributes were availability of appropriately qualified staff within 10 minutes of the check-in process and provision of after-hour care. The better value of 1, closer to 1, usually indicates that the satisfaction can be improved, and a large absolute value of worse that is closer to 1 indicates that providing such attribute only prevents dissatisfaction. And the values that are closer to 0 usually have very little effect on satisfaction or dissatisfaction. Some of the patient suggestions that we received were the convenience of flexible and affordable payment plans, adequate capacity of qualified medical staff, and also in the comments we noticed that most of their customers really preferred having entertainment options during their longer waiting hours. So moving on to the statistical analysis, we used our Kano questionnaire and performed the calculated the Cronbach's alpha, which is the measure of internal consistency of the instrument that we used, the Kano survey. And it is usually expressed as a number between 0 and 1, and a 0.7 or higher is usually considered acceptable, and our survey had 0.92. We also performed the chi-square test to see if we calculated the chi-square values for every quality attribute, and we noticed that all of those were higher than the critical chi-square values. So what it says is that the difference between the actual ratings is statistically significant, because our hypothesis was that it would be uniform, that each category with our questionable, must be, one-dimensional, attractive, indifferent, and reverse, that it would be a uniform distribution, that there would not be any different response, that none of these categories would have a higher value. So that null hypothesis was proved false with our chi-square test. And we've noticed that all of these attributes had a p-value of 0.0. Then we performed the Fisher's exact test to look at whether, based on the gender, based on the age, the health status, citizenship, if there would be any differences between those demographics. So within male and female, the attributes that had no similarity, that they responded differently, was availability of qualified medical staff within 10 minutes of the check-in process, as well as provision of complete information of the prescribed medication. So one of the attribute that you see here, provision of complete information of prescribed medication. When we looked at the male and female, with the female, it was a must-be attribute, whereas with a male, it was more of a one-dimensional. So we could see the differences in how they viewed these different quality attributes. And with age group, again, there were no similarities between the different age groups when it comes to provision of complete information of prescribed medication and provision of adequate information about illness and treatment. With health status, however, all the patients responded similarly on all the attributes. With citizenship, when we looked at international non-immigrants as well as US citizens, there was a difference in how they responded to design of the walk-in facility being patient-friendly, where non-citizens usually consider that to be unattractive, whereas with the citizens, this was considered to be a one-dimensional attribute. So there were really differences between how these respondents answered these quality attributes and how they viewed that in terms of questionable, must be, attractive, one-dimensional, and reverse. With marital status, again, there were differences between provision of adequate information about illness and treatment and confidence with the care provided by the medical staff. With the parental status, there were differences on the attribute provision of complete information of the prescribed medication. So with respondents who had kids, they considered this to be as a must-be attribute. However, respondents with no kids were indifferent to it. So that Fisher's exact test really gave us information on how different demographics affect the customer needs and their perceptions. Along with that, we've also calculated the effect sizes. We calculated the Kramer's V as we had larger contingency tables with different responses. And we looked at these demographics and tried to estimate the strength of the relationship between the variables. So with gender, attributes such as availability of appropriately qualified medical staff within 10 minutes of check-in process and provision of information about the delays had really strong association. With age groups, design of the walk-in facility being patient-friendly and clear instructions on follow-up care had moderate association. With health status, attributes such as medical staff inquiring about satisfaction with care provided and confidence with care provided by medical staff had moderate association with the health status. With the citizenship, again, the design of the walk-in clinic facility and being patient-friendly had a relatively strong association. With marital status, provision of adequate information about illness and treatment and confidence with the care provided had moderate association. So we try to look at how it would impact and what the effect sizes were. So by implementing this methodology, it really gave us information on how to approach gathering and classifying voice of the patients, their needs, by really looking at customizing these service quality attributes for those individual healthcare units and trying to understand how they would impact both patient satisfaction and dissatisfaction, and how they would differ based on the type of care and service provided, and how there are differences between various demographics. And this methodology really does eliminate some of the issues that we've seen when we conducted the systematic literature review, is that most of the studies really used one single scale. However, with this methodology and looking at the Kano model, it really does allow us to look at individual healthcare units and understand these demographics and how that would impact the patient satisfaction, and how over time these needs can vary, and how based on locational analysis, how that would change with different communities. And it can be used to make informed decisions when it comes to customization of care and treatment options. Two of the instruments that are more frequently used, such as Net Promoter Score, really does not only looks at detractors and promoters, but eliminates the information that is provided by a lot of the passives. That really does not take into consideration every single respondent and how that impacts their perceptions and experiences. Along with the ServQual, which is the service quality scale, that also looks at different dimensions such as reliability, assurance, tangible empathy, and responsiveness. But it has a predetermined 22-point scale, and that is generically applied to all the different types of service units. So this approach, this methodology really eliminates some of the issues that we've noticed. And this study was also conducted at the Student Health Care Services at Missouri S&T, where the service unit really does mimic the walk-in clinics. So we've only changed some of the attributes. However, we did observe that most of the responses and the categorization of service quality attributes was similar to the walk-in clinics. Okay. That concludes my presentation. I really want to thank Deborah Hopen as she continued to provide a lot of feedback and support during my doctoral research. Her webinars really helped me. Her constant guidance through emails and trying to work with me on my paper and being my co-author. I'm really thankful to her, and I do really miss her. I would also like to thank IAQ, Ms. Kaim, and Dr. Molnar for giving me this opportunity to present my research. And if you have any questions, I'd be happy to answer them right now.
So it would be most helpful, I think, if you would raise your hands if you would like to make a comment or ask a question so that I can sort of help manage that. So Pedro, if you'd like to go first.
Sure. So congratulations. I think it's a very interesting contribution and research. I was just curious. I think you have not evaluated what will be the people's perception as we move to remote and online consultation modes. For instance, I've been recently to Saudi Arabia, and Ayad is with us, and they have a wonderful national system where I can talk with my medical doctor with all the records, just having a mobile phone connected with whoever is on the other side of the line. So any thoughts on what might be the impact? I guess you have not assessed that if I saw the questions that you raised, but any feelings, would that be an attractive kind of feature
Yes.
for most people these days? What are your views on the digital transformation that even the pandemic situation is making more and more become as an alternative?
Yes. So I would say that a lot of the insurance providers and healthcare organizations are moving to the telehealth, which is mostly via phone as well as video. It is convenient. However, there are certain restrictions on how many number of visits that you can really access. I do think that most patients really do like in-person visits so that they can ask a lot of questions, that there is no time limit, that they can actually interact with them on a face-to-face basis. It does help to have these video calls and phone calls with the providers and trying to ask them questions. However, I do think that there will be delays in terms of if they need to get tested for anything. So a lot of the laboratory tests that need to be done, because we cannot access a lot of them right now, and we cannot commute to places to get those tests done. I do think the patient satisfaction or they might be really frustrated with the delays in terms of testing and trying to get information on the medications that they need to take and the treatment options that they need to consider.
Thank you. Any other questions or comments? Pedro, so anybody else have any questions or comments? If you can't figure out how to raise your hand, unmute yourself and speak up.
Hi, Liz. It's Grace.
Hey, Grace, go ahead.
Yeah, great presentation, Tejaswi. Thank you for this great research. Just a quick question on, I think I may have missed this, on developing the survey. How did you develop the different domains and different questions?
So what I've done is with both walk-in clinics as well as the student health services. First of all, we tried to customize it to both those individual healthcare units. I did look at the HCAP survey. I did look at a lot of net promoter score surveys that are used by a lot of different hospitals, which are readily available through databases. I've accessed those. And I've also looked at individual units to figure out what type of services they do provide, their service of operation hours. And I gathered all that information and used the existing Kano model studies to combine and collect a lot of questions. So I had over 120 questions, and Deborah Hopen really worked with me to come down to these 21 quality attributes, and she provided a lot of information on how to look at the functional aspect and dysfunctional aspect. So I did have a lot of questions that I had to come down to more manageable, so that to try to look at, how many number of questions will the customers or the patients would really consider taking that survey. And, most of the surveys should be done within 5 or 10 minutes. So I kept that in mind as well.
Good, thank you.
Did you get the chance to pilot it to a few subjects?
Yes, I did.
Okay, thank you.
Thank you.
Thank you, Grace. Jamie?
Yes, so I wanted to ask kind of maybe two parts. What were some of the biggest challenges in the project? And then what are your future plans?
So biggest challenges that I would say was with just trying to get these surveys out and trying to get them to different avenues. So I had to use a lot of social media, websites, and gathering these responses really does take a lot of time. So this was done with over a few months, I think about 4 months, and I did end up having only 127 respondents. So that is one of the biggest challenges. The response rate is really low when it comes to surveys, and trying to trim down over 120 questions to more manageable 21 questions was also a little bit challenging, because when I was looking at it, I thought every attribute was important, and I did have some that were redundant, so I had to trim those down as well. And my future plans, currently I'm trying to work on identifying how different factors, or what are the selection factors that really impact the quality improvement projects that are undertaken by the healthcare organizations.
Great, thank you.
Hello, Rich?
Yes.
May I?
Yes, please, Dr. Kano.
Yeah, so thank you very much. Very interesting presentation. Let me ask one question. Could you show me that attribute which is judged as attractive quality? Could you show me the attribute which is judged attribute? No, attractive quality.
The availability of appropriately qualified medical staff within 10 minutes and a provision of after-hours care.
So could you speak slowly? What is that? What are they? What is one? You say 2 cases. Yeah.
Yes. Availability of staff.
Okay. I see. Understand. It's interesting result. So that say in this case, this one-dimensional is very many. So I think in this case, now that I think let me make a comment that, so it's very interesting, but in this study, in particular, I think like healthcare issue, it's a very delicate, sensitive issue. So in this situation, a very important thing that to say, how you can find the latent requirement. If they, of course, it depends on that your objective. Your objective is focused to that, say, more something also just to say, try to improve the quality of the routine level. Or if you want to, a service clinic want to innovate in this situation. In the case, if you want to get to something innovative, in this case, you need to get to the attractive quality, or say like indifferent quality. Those kind of things is very important. But in this situation, how to develop that attractive attribute, that part is very important point. So that in the case that say, maybe in this area, also, as you mentioned in your conclusion, very important thing is that to say how to make the attribute arrange based on that customized way. Those kind of things are also important. If you are in the future study, if you may consider this point, I think it will become much more interesting, and also not only useful for that the improvement of the daily quality, but also that say work for that innovation, I think.
Yes.
Thank you very much.
Thank you for your comment. I will consider that in my future studies.
Anybody else have any questions or comments?
I don't know if you can see my hand or not. This is Bob King. Two quick points. First point is I was very delighted to see the thoroughness of your use of the Kano motto because I think some people use it very casually, and it was good to see your thoroughness. The second is I will send you some information on the Maple Hill Medical Center in Goshen, Indiana. And they're extremely innovative, and everything is done with a team. And it really would blow off the chart what you were saying about the appropriate medical person being available, because they have everything is done with a team. And first thing in the morning and at lunchtime, they go over everybody who's going to come in that day and all the things that they need. And as a result, they not only provide the service of expected quality, but also exciting quality, taking care of all the tests and different things that will help their health. And their success rate is huge. But thank you very much. Your presentation was very insightful.
Thank you.
Anybody else have anything? Okay, well, thank you very much, and congratulations again on receiving the prize. And I'll put those in the mail to you tomorrow.
Okay, thank you.